everyone. Today my title is A Comparative Study of Axial Length Measurement Using Contact versus Immersion Technique in Patients Undergoing Small Incision Cataract Surgery and its Impact on Postoperative Refractive Status of Eye. No financial interest. Introduction. Important step in ocular biometry is to obtain desired postoperative refractive outcome, for which standardization of techniques is required to ensure accurate measurements of IOL power. A-scan ultrasound is a technique which involves passing an ultrasonic beam via a transducer, which after hitting intraocular structures is returned back and displayed as ocular spikes on the monitor. A-scan ultrasound can be obtained either by contact, immersion or optical methods. An error of 1 mm in axial length results in a refractive error of approximately 2.35 diopter error of IOL power in an average eye of 23.5 mm. Aim to compare contact and immersion technique for measuring axial length and to see the impact on postoperative refractive status of eye. Inclusion criteria: patients aged between 50 to 70 years with age-related cataract and axial length measuring between 22 to 25 mm. And patients who have potential for good visual acuity, patients willing to give consent for the study. Exclusion criteria: patients with nuclear sclerosis above grade 3, and history of cornea and retinal pathology, any previous surgery to the eye or trauma, preoperative refractive error greater than 4D sphere or 2D cylinder, history of any systemic illness. Materials and methods: study type is comparative analytical study, sample size is 44, place of study is Department of Ophthalmology, SVS Medical College, Mehboob, study time July 2022 to April 2023. Approval was obtained from Institutional Ethical Committee. K1, K2 values are obtained and axial length was measured using A-scan. Immersion technique was done first, followed by contact technique by the same examiner. A pressure scleral immersion shell was used to support the probe and normal saline was used as coupling fluid. The chamber was filled with saline using a 10 cc syringe connected to a silicone tube. An automated sequence of 10 measurement readings was taken according to the preset amplitude and timing criteria for ultrasound reflections with one application of the shell and probe. In contact technique, the A-scan probe was placed gently on the cornea and an automated sequence of 10 reliable readings with characteristics peak were taken. The standard deviation was set less than 0.05. Grouping: cataract surgery was done by small incision 6.2 mm triplanar corneoscleral tunnel on steeper meridian serially. The first patient was allotted group I and second patient group C. Third again group I and so on till 22 patients had been operated in each group. IOL power obtained for both techniques was calculated using SRK2 formula. Postoperatively, at the end of 6 weeks, we compared the residual spherical error in diopters between two groups. Statistical analysis: student t-test was used and p-value less than 0.05 was considered significant. Results: the biometry values of 44 eyes of 44 patients were taken. Their ages ranged from 45 to 60 years. There were 22 males and 22 females. The mean axial length obtained with immersion and contact technique are 22.92 and 22.61 mm. At the end of 6 weeks, post-op residual spherical refractive error was noted during the follow-up period. Residual spherical error less than plus or minus 0.5 is 17 in group I and 14 in group C. Greater than 0.52 plus or minus 1.50 is 5 in group I and 8 in group C. Independent t-tests had shown that the difference was found to be statistically insignificant. Discussion: measuring axial length is a key to calculation of intraocular lens power. In our study, immersion technique had given comparatively long axial length and contact technique. In immersion technique, there is no direct contact of A-scan probe with the cornea, thereby avoiding corneal compression. There was statistically significant difference in the mean values obtained using contact and immersion technique. There was a difference of 0.31 plus or minus 0.13 mm between two techniques. This can impact the IOL power to be implanted and postoperative refraction. Limitation: sample size of the study was small. While measuring the axial length, anterior chamber depth, lens thickness were not taken into account. Eyes with short and long axial lengths were not taken into account, which would cause great difference in the IOL power obtained. Conclusion: in this study, there was a significant difference in axial length measurement using immersion and contact technique. In terms of postoperative residual spherical error, there was comparatively better visual outcome in immersion than contact group, thereby concluding immersion technique is more preferable than contact technique. These are the differences. Thank you.
So how do you confirm whether your immersion axial length is correct or not? You have done for a eye. Okay, for that patient. How do you confirm that axial length is correct for that patient or not?
Among the 10 readings with p-value,
You have got very good peaks.
highest
Okay,
peak.
you have taken 10 readings.
Highest peaks should be
Any other?
p value less than 0.05.
Any other? So we should always measure the other eye also. Okay, when you're doing for a total cataract, you're doing an immersion method, measure the other eye also. Okay, for most of the 80% of the patients, we have the other eye axial length similar. Only in abnormal eyes, you might find difference in axial length for both the eyes, but in 80% of the cases, the axial length is always similar in both the eyes. So in order to confirm your reading, you can measure the other eye axial length. Okay.